Okay.
Hello. So tonight's topic is diabetes. Uh, but yeah, we want to leave it open before we get started. Anyone that's new to the classes, and feel free to introduce yourselves and how you found out about the classes. And then after I do a little presentation on diabetes, then we have a couple of guest speakers, special guest speakers that are gonna tell their story and real inspiring. So hope you stick around for that.
So I'm new to the meeting. My name is Liz Denicky, and I got into all this because of my cousin who had a heart attack and started on the heart diet and has had great success with that. And then we would create recipes every once in a while and chat about how to do the no oil diet. And then Nathaniel, who is on tonight, walked into my house and told me what I was going to do for my retirement plan.
Yeah.
And so I've
And
kind of been
I,
doing it ever since.
nice. And I was functioning as your nurse practitioner doing your annual Medicare home
Exactly.
assessment.
Exactly. Exactly. And he saw, because I've studied at cooking schools and stuff, and he said, "Oh," he said, "and now you know how to do this. Now you're a vegetarian, but you're not vegan yet." I said, "No." He said, "That's all right. You'll get there." it's it's not a big leap. And I stopped eating cheese immediately. And it's just been a very interesting experience. So I'm very grateful to him for doing that. Very grateful for him for being so outspoken. And I found out about your group when Nathaniel was in Eugene, and he said, "Are there any vegan groups down here?" And I said, "I don't know, but there ought to be. There must be." And I found this group, and but I didn't realize you met weekly or biweekly. And this would be a great support because it is lonely out here as a vegan. It's and people look at you like you're just off your rocker a little bit, at least here where I am. And that doesn't bother me. I mean, people have looked at me like that all my life, but it's not hard being vegan. It's very hard being whole foods, plant-based, no oil. That is very challenging for me. So it would be good to get some support for that.
Well, welcome, Liz. Happy to have you.
Thank you.
And thank you,
Let me just tell
Nathaniel, for.
Liz, can I just interject here? I live in
Ah,
a town of 50 people in the middle of cattle country of Montana, cattle
oh
all around me,
my.
and I am the only one, well, my husband, that eats whole food plant-based. And they all look at me a little strange.
It is hard in Montana. My sister lives in Prineville and
Oh,
she's a vegetarian, and it's not easy.
it's not, it's
Mhm.
not. But I would rather, my mom died from Alzheimer's, her mother died from a heart attack. I want to live to be 85, whatever it is. I want to be healthy. And I'm
Just want,
77 and I'm good. Woohoo!
well,
I love this group.
I'm 73, and so I'm right behind you.
Yeah,
And so but I think it's really important to have a team behind you.
yes, it is.
And so I'm very happy to hear this. And of course, Nathaniel's the one who went and now is dragging me along. So, so
That's great. Thank you for sharing. Anybody else want to chime in?
Hey there, this is Sarah. And if you don't want to, if this is totally off topic, let me know. But I just want to know if anybody knows about taking care of dogs in whole food plant-based way.
Yeah, there's actually I have a couple veterinarian friends down in Southern California in Pomona, California, who actually have done studies on a product called V-Dog. It's like vegan dog. And so they've added, there's one amino acid that's required, that's apparently not common with just plants, but they add it to the food. We've fed our dog that for I don't know, a year and a half, 2 years, and did really well. So dogs can do vegan diets. And they did a study over a year period of time, found their health was identical.
Because there are so many dogs, my dog included, that have a lot of problems, and I think it's probably diet. I know it's environment too, but
Yes,
yeah. Thank you.
you're welcome. Anybody else? All right, Scott, might as well get started, and we're going to hear from Stu and Sharon Stephen after your presentation, and then we'll see if our other student is available to chime in if he'd like.
All right, let me share my screen. I'll just show, since we have maybe a new person or two, let me just show the website real quick. So this is the livelifestylemedicine.com website. So if you're new, definitely come here and subscribe to the weekly class newsletter, because that gives you all the information about what's coming up next week and all the other supportive community activities we do and everything. So definitely subscribe to the newsletter. And then the only other thing I just want to show, so I don't spend much of time on it, is scroll down here to the website tutorial, click on this. It's a 20-minute recording of me giving a tour of the website, and just check it out, because I go through the entire website, what are all the resources here, and all the support you can get. So definitely check those two things out. So let me back here. Get my PowerPoint here.
We can see it.
Great. All right, and then I guess everyone mute themselves if you can, and then I'll go through some of these slides, and then I'm not going to show all the every slide. I just want to kind of give you a little introduction, and then I want to talk to you about insulin resistance, because that'll segue in nicely to the different, as I talk about the different types of diabetes, and then insulin resistance, and how all the types of diabetes are affected by insulin resistance, and how important it is. And then that'll be a good segue to Sharon and Stu, who are going to talk about diabetes, their personal story with diabetes. All right, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in. And I like that quote, because kind of how we treat the types of diabetes is we're just treating symptoms. We're not really treating the cause of diabetes. We're just kind of looking at their blood sugar and trying to keep the whatever we can do from medication or diet standpoint, try to keep the blood sugars low and stable. And that's kind of the whole focus. And instead of figuring out, well, why is everyone developing diabetes? Why is there so much diabetes? And actually preventing it and treating the cause of it. So I like that quote there. So we're going to be mostly talking about type 2 diabetes tonight. That's 90 to 95% of all diabetes, and it's purely caused by insulin resistance. There is some genetic component with it. So there are certain populations that are at higher risk. So some of the most common are Latino population, Native American population, even Asian population seems to be predisposed. So much higher prevalence among those populations, but so a little bit of a genetic component, but it's mostly diet and lifestyle caused by insulin resistance. So we'll be talking a lot about that. And then prediabetes is an A1C between 5.7% and 6.4%. So you'll sometimes get that number at your doctor's office. So a number of A1C of 5.6% and below is considered normal. And then 5.7 to 6.4, we call that pre-diabetes. And then diabetes would be 6.5% and above. And also you can define it by a fasting blood sugar between 100 and 125 is pre-diabetes. Normal would be below 100 for fasting blood sugar. And then 126 or higher would be diabetes for a fasting blood sugar. And then there's also random blood sugar of 200 or more is considered diabetes, no matter what type of diabetes. It just technically just a random poke, whether you just ate or not. A random blood sugar of 200 or more is also. And then type 1 diabetes is actually autoimmune type of diabetes. We used to call it juvenile onset because we mostly saw it in kids and adolescents, young adults, but it can actually happen anytime, which we'll talk about on number 4 here in a second. But type 1 diabetes is autoimmune. What that means is your own immune system attacks the cells in the pancreas that make insulin. And so the person just doesn't make insulin anymore. And so they'll have their blood sugars will shoot through the roof, and they have to inject diabetes. And so the key with type 1 diabetes is that no matter how healthy your diet and lifestyle is, you'll always have to inject insulin because you just don't make it anymore. So you have to inject insulin. So, but we'll talk about how you can actually maybe need a lot less insulin if you have type 1 diabetes, if you can actually reverse the insulin resistance, because even people with type 1 diabetes develop insulin resistance also, and we're learning that insulin resistance is the real culprit, the real bad guy in the whole process here. And then I want to get too involved in type 1.5 because it's, you don't see it too often, but 1.5, that LADA stands for latent autoimmune diabetes in adults, is what that stands for. And really what that is we thought the person had type 2 diabetes, and probably they did at one time, but then all of a sudden their blood sugars are really high no matter what medications you put them on, and they end up having to put them on insulin because they just aren't making enough insulin anymore. And it's because their immune system has also attacked their cells that make insulin in the pancreas. And so, and there's some tests you can do, fasting C-peptide, and a couple of antibody tests you can order to see if that your patient, the person has the type 1.5. So it's kind of like type 1. You just think of it as like type 1, but you get it when you're older, when you initially had type 2 and then develop this type 1.5. And then gestational diabetes is diabetes during pregnancy. And usually once you deliver the baby, the diabetes goes away in most cases, but we know that women that had gestational diabetes, they're at higher risk for developing type 2 diabetes later on in life or at any time. So it's also seems that the pregnancy kind of puts enough stress on the body that causes more insulin resistance, and then you end up with diabetes. But then when you deliver the baby, it kind of seems to go away. But again, it many times comes back. But then before I move on, so I can answer any questions about these different types. But before I do that, let me just give you guys a little brief story of my diabetes journey and how I got into become so interested in diabetes. So most of you guys here know me, but I'm Scott Wagnon. I'm a physician assistant. I've been a physician assistant for 20 years. And my diabetes story started back in 2008. So I graduated PA school in 2005. And the first job I was in a clinic where we had a really kind of a tight budget there. And we tried to keep everything in-house, all the providers. And so instead of just always referring patients out to specialists all the time, we tried to refer within our own practice people that had specific interests in certain areas of medicine, certain specialties. And even though I was doing family practice, community health, diabetes was my real interest area. So what that means is I read everything I could get a hold of, really was well educated on the studies, and it was just a really big interest area, diabetes. And so I often got the most challenging diabetes patients were sent to me because they knew I was really like to take care of patients with diabetes. And at the time, the whole paradigm of treating diabetes was to treat really aggressively. And so like get patients on insulin as soon as possible and get them on all the different medications. And of course, in 2005, we didn't have as many medications for diabetes as we do now. But we still had a few, and so I was really aggressive at getting people on medications, getting their blood sugars down to as close as normal as possible, because the thought at the time was, well, if we can get people's blood sugars essentially normal, like someone without diabetes, then maybe they won't develop the heart attacks and the strokes and the kidney failure and the blindness and the amputations and the neuropathy and all those kinds of things. Maybe those things wouldn't happen if we made the blood sugars normal. And so if you think about it, it kind of makes sense, but it ends up that's not what happened. And so in 2008, let me jump to that. I went to the American Diabetes Association has an annual conference every year. And in 2008, it was down in San Francisco, and I went to it. And at the time, there was 3 big studies that were being done. These big studies on diabetes were going to be published. And so we were going to get to see the results. And what we were hoping it was going to show is that the people, just like I said, the people that we treated really aggressively did much better. And what ended up happening is they stopped 2 of the 3 studies early because the aggressive arm of the study, the patients were dying. There was a higher rate of death. And so they had to stop the studies early. And so it was like, oh my gosh, what's going on? And kind of in hindsight, there was a slight benefit to reducing some of the eye disease, and some of the kidney disease was a little bit slowed down in the people that were treated aggressively, but more people were dying of heart attacks and strokes. And so the kind of in hindsight, the thought being is that the more aggressive patients we were being treated really aggressively, they were getting more hypoglycemia, more low blood sugars, which makes sense because we're driving their blood sugars down to normal with all these medications and insulin, and they were getting more hypoglycemia, and that puts a lot of stress on the body. So if you think about someone with diabetes, especially type 2 diabetes, they're at really high risk for heart attacks and strokes, because someone with diabetes has the same risk of having a heart attack or a stroke as someone that has already had a heart attack or a stroke. We call it a risk equivalent. And so these are really high risk patients, and these aggressive treated patients where we think it does put so much stress on the body, and because of that, they were dying sooner, so they had to stop those studies. So at that time, most of you that know my story, I didn't learn about whole food plant-based nutrition until 2012. So at that time, I wasn't educated at all on nutrition, but I was just like, oh, it kind of made me rethink. All of us made us rethink our approach. We got to, this isn't the answer, is not treating people super aggressively. So I wanted to give you that little bit of background so you kind of know where I'm coming from as I talk about this stuff going forward. So does anyone have any questions about the different types of diabetes? You don't have to have a really high level of understanding of it, just kind of knowing the major differences, especially between type 2 and type 1. Okay. I know people were probably muted, except for I hear some background noise in one, but all right, we'll just give you a couple quick statistics. 38.4 million people in the United States have diabetes, 97.6 million with pre-diabetes, and 1 out of 10 don't even know they have it. So that's 136 million Americans with diabetes or pre-diabetes, which is a third of the population. So this was in 2023. It's probably I haven't got any updated statistics since then. This is from the CDC. And high cost, $413 billion in direct and indirect costs. So lost work time and direct costs, and probably it's even higher now because if that's 2022. Because think about Ozempic and all those drugs. Those aren't being covered for weight loss these days, but they're still being covered for diabetes. So those are super expensive, and so I'm sure this number's much higher now as we have so many of our patients with type 2 diabetes on these GLP-1s. So I won't show this video. This just talks about prevalence of diabetes. This is a Dr. Greger video. I wanted to jump right to what insulin resistance is and the impact it has. And then I'll show you a video from Dr. Greger that demonstrates on a cellular level what's happening with insulin resistance. Okay, so what is insulin resistance? So it is caused by the storage of fat in tissues that are not designed to store fat. So this is the best way to explain what it is. So what it is our body is supposed to store fat in the subcutaneous tissue, in our hips, our thighs, our around, not as much in the middle, but sometimes we do there too, but just all throughout the subcutaneous tissue throughout your body, kind of marbled in everywhere. That's where excess calories are supposed to be stored. But what we see, what seems to happen with people, and we're learning more and more about this all the time, is that everybody has a certain kind of lean body mass or a fat distribution threshold. So everyone can think of it this way. That's why you see so many people with so many different shapes and sizes. Everybody puts fat in different places. And so everyone seems to be kind of, maybe a lot of it is genetic, predisposed to putting fat in certain places. So we're designed to put the fat in our subcutaneous tissue, in our fat cells, because that's kind of our, as Dr. John McDougall would say, the metabolic dollar is the fat. So we're storing it for when we have famine and we're fasting and not eating later, so we can draw from our fat stores to survive. And that's the by design where we're supposed to store fat. But you think about it, so some people don't, or just that goes way overboard. Have you guys ever seen, that show, My 600-Pound Life? Those really, really people that are really, really obese. And if you think about that doesn't really make much sense, because it's like that from a survival standpoint, that's not good, because you're not going to be able to run away from the predator. You're not going to be able to climb a tree because you just have way too much fat. So that's very unnatural, and that's not something that we would be selected for survival. And what's kind of interesting is people that are that big, that are 600 pounds or more, many times those people do not have diabetes. They don't have, even a lot of times don't even have insulin resistance. And so some theories about insulin resistance, and Dr. John McDougall had this opinion, is that insulin resistance actually might be a compensatory mechanism. And so because it's like, well, it's not good from a survival standpoint to put so much fat in the subcutaneous tissue. We need to put it somewhere else. We need to figure out where else to put the fat. And where fat is being deposited with insulin resistance is in the muscle cells, in the liver cells, in the pancreas, around the visceral organs. So all that metabolically active fat you always hear about that's so bad around the organs, that's essentially being caused by insulin resistance. So fat is being put inside your muscle cells and your liver cells and your pancreas and throughout the organs, basically. So it's fat being stored in the organs. And it's having really bad consequences when it comes to diabetes and our health. But some people seem to be putting more fat there. And one of the things that we got a hint to this was in the Asian population. So because in history, the people from China, Japan, Korea, the Philippines, we almost never saw anyone that was overweight. We almost never saw anyone with diabetes in these populations, because they were eating mostly rice and vegetables, a little bit of fish, but mostly sweet potatoes, rice, vegetables, noodles. These were their traditional diets for thousands of years. And we just didn't see diabetes or even heart disease and things like that. It wasn't until they started westernizing their diets. Now you can go to Japan and go to Kentucky Fried Chicken and Pizza Hut and all this kind of stuff. And so we were starting to see diabetes in the Asian population before they were even getting overweight. So we were like, because in America, most people that have type 2 diabetes are usually 20 pounds overweight, 30, 40, maybe 50 pounds overweight is pretty typical. We usually didn't see it too often early on in people that were normal weight. Of course, it's hard these days. It's hard to find people. Only about less than a third of the population is normal weight in the United States now. But so that was kind of our thought, was like, oh, most people with type 2 diabetes in the States are overweight or mildly obese, and that wasn't happening in Japan. They were like people that were already having type 2 diabetes, and you looked at them and they looked normal. They didn't look overweight at all. And so we were trying to figure it out. What's going on? Yeah, we know their diets changed, but why aren't they overweight? Why are they developing diabetes before they're even overweight? And so we knew there had to be something more to it. And then they ended up developing a technology called magnetic resonance spectroscopy, MR spectroscans. And what the MR spectroscan will show you is where fat is distributed in the body. So you can do an image and see where fat is. And what they found in the Asian population is the fat was in the muscles, it was in the liver, it was in the pancreas, and their visceral organs. So it wasn't in the subcutaneous tissue. It's in the places where insulin resistance tends to put the fat. And so they're starting to catch up now. I mean, there's a lot more overweight people in these countries now because they've really westernized their diet. And so I just wanted to kind of give you that little kind of history on insulin resistance. And so now the next slide I want to show you is why is insulin resistance so bad? Because it has influences over all of these things here. And so coronary artery disease, which is heart disease, cancer, all the types of diabetes, even type 1, 1.5, pre-diabetes, chronic kidney disease, Alzheimer's. So a lot of people are calling Alzheimer's disease type 3 diabetes because what it is insulin resistance of the brain. So it's what we call glucose dysregulation in the brain is one of the key components of Alzheimer's disease. Fatty liver, just what you would think, because we put fat in the liver, right? Just like in the muscle cells. High blood pressure, high cholesterol, obesity, polycystic ovarian syndrome, which is women can get when they have excess male hormones in their body, and they more hair growth, lots of cysts in the ovaries, the estrogen gets suppressed, and they usually can't ovulate, or they can't get pregnant. And so insulin resistance is a big influence on that, because a lot of times when these women with PCOS can't get pregnant, and then once you can reverse their insulin resistance with diet and lifestyle, they suddenly start having menstruation, and they can actually get pregnant. And then things like neuropathy, the retinopathy in the eyes, erectile dysfunction. So all of the kind of the complications of diabetes that I talked about earlier, insulin resistance seems to be kind of the root cause of all of these things. And we weren't treating the insulin resistance when we were treating those patients aggressively by just artificially lowering their blood sugar with whatever medications we could throw at them. That wasn't treating the insulin resistance. That was just lowering the blood sugar. So does that make sense? Before I kind of show a video of demonstrating insulin resistance, does anyone have any questions about just the basics of insulin resistance and any of these conditions here and how they are influenced by that?
Got a question in the chat.
Sure. What does it say? Someone can read it for me. I can't see the chat from my view.
Beth wants to know the causes or the mechanisms for gestational diabetes, and if there are fewer cases with whole food plant-based.
Yeah, I think there are definitely fewer cases with whole food plant-based. It seems to be there's so many things that physiologically change when you're pregnant, and so I think the thought is it increases insulin resistance just because of all the excess fluids and weight and all the hormone changes from pregnancy. Yeah, there might be a OBGYN that could answer that in more detail than myself, but I think that's kind of the thought, because what seems to be what happens when all those which, like a lot of conditions when you're pregnant that go away after you deliver the baby, it's just that shift in the hormones, the shift in the body fluids and different things, and just the stress on the body of pregnancy, that it seems to at least temporarily go away once the mother delivers the baby. Okay, I'm not going to show this one. I'm going to show this video, and this is going to demonstrate what insulin resistance looks like from a cellular level, what's happening in there, and then I'll unshare, and then we can have a discussion about it, because this is really important to understand.
Studies dating back nearly a century noted a striking finding. If you take young healthy people and split them up into two groups, half on a fat-rich diet and the other half on a carb-rich diet, within just 2 days, this is what happens. The glucose intolerance skyrockets in the fatty diet group. In response to the same sugar-water challenge, the group that had been shoveling in fat ended up with twice the blood sugar. As the amount of fat in the diet goes up, so does one's blood sugar spikes. It would take scientists nearly 7 decades to unravel this mystery, but it would end up holding the key to our current understanding of the cause of type 2 diabetes. When athletes carb load before a race, they're trying to build up the fuel supply within their muscles. They break down the starch into glucose in our digestive tract. It circulates as blood glucose, blood sugar, and is taken up by our muscles to be stored and burned for energy. Blood sugar, though, is like a vampire. It needs an invitation to come into our cells, and that invitation is insulin. Here's a muscle cell. Here's some blood sugar outside, waiting patiently to come in. Insulin is the key that unlocks the door to let sugar in our blood enter the muscle cell. When insulin attaches to the insulin receptor, it activates an enzyme, which activates another enzyme, which activates two more enzymes, which finally activates glucose transport, which acts as a gateway for glucose to enter the cell. So insulin is the key that unlocks the door into our muscle cells. What if there was no insulin, though? Well, blood sugar would be stuck out in the bloodstream, banging on the door to our muscles, and not be able to get inside, and so with nowhere to go, sugar levels would rise and rise. That's what happens in type 1 diabetes. The cells in the pancreas that make insulin get destroyed, and without insulin, sugar in the blood can't get out of the blood into the muscles, and blood sugar rises. But there's a second way we could end up with high blood sugar. What if there's enough insulin, but the insulin doesn't work? The key is there, but something's gummed up the lock. This is called insulin resistance. Our muscle cells become resistant to the effect of insulin. What's gumming up the door locks in our muscle cells, preventing insulin from letting sugar in? Fat. What's called intramyocellular lipid, fat inside our muscle cells. Fat in the bloodstream can build up inside the muscle cell, creating toxic fatty breakdown products and free radicals that can block the signaling pathway process. So no matter how much insulin we have out in our blood, it's not able to open the glucose gates, and blood sugar levels build up in the blood. This mechanism by which fat, specifically saturated fat, induces insulin resistance wasn't known until fancy MRI techniques were developed to see what was happening inside people's muscles as fat was infused into their bloodstream. That's how they found out that elevation of fat levels in the blood causes insulin resistance by inhibition of glucose transport into the muscles. And this can happen within just 3 hours. One hit of fat can start causing insulin resistance, inhibiting glucose uptake after just 160 minutes. Same thing happens in adolescents. You infuse fat into their bloodstream, it builds up in their muscles and decreases their insulin sensitivity, showing that increased fat in the blood can be an important contributor of insulin resistance. Then you can do the opposite experiment, lower the fat in people's blood, and the insulin resistance comes right down. Clear the fat out of the blood, and you can clear the sugar out of the blood. So that explains this finding. On a high-fat diet, the ketogenic diet, insulin doesn't work as well. Our bodies are insulin resistant. But as the amount of fat in our diet gets lower and lower, insulin works better and better. This is a clear demonstration that the sugar tolerance of even healthy individuals can be impaired by administering a low-carb, high-fat diet. But we can decrease insulin resistance, the cause of prediabetes, the cause of type 2 diabetes, by decreasing saturated fat intake.
Right. I want to talk to go off that video to talk about the keto, what I call the keto caveat. So you just heard him say that eating a low carb, high fat diet worsens insulin resistance. But then you might know people that, and you always hear the low carb people talk about it all the time, that, oh, well, yeah, when I went on a low carb, high protein, ketogenic type of a diet, my people with diabetes, my insulin requirements went down, my blood sugar went down, my numbers got better, everything looked better. They looked on paper like they were better, but the reason is because their insulin resistance actually got worse, but you don't know it. It's being hidden by the fact they're eating really low on carbohydrates. So their sugars stay low and stable because they're not challenging their system with carbohydrate, with glucose. And you might think, here's a good analogy. I think Dr. Greger uses this analogy. So like if you fell down and broke your hip, your choices would be, well, I'm not gonna have surgery and fix it or do physical therapy. I'm just gonna stay in a wheelchair the rest of my life. That's the equivalent of going on a low carb diet. when it comes to diabetes and insulin resistance. So if you just don't try to get up and walk, your hip won't hurt, and you'll look normal. You'll just be able to get around in a wheelchair. But if you want to actually fix the problem, get rid of the insulin resistance, you want to actually fix the problem there, then you want to have the surgery on the hip and do physical therapy and get back to normal. Because normal physiology, someone that doesn't have insulin resistance, is to have no insulin resistance and high insulin sensitivity. So think of it, if you guys can see my hand. So you want to have low or no insulin resistance, but you want to have high insulin sensitivity. And what that means is when you eat foods, normal foods and carbohydrates, and because that's our food is carbohydrates with some fat and some protein. Those are our 3 macronutrients. That healthiest populations on the planet eat over 80% carbohydrate, because our bodies can use glucose. It can also use fat for energy. And so you want to actually be able to eat carbohydrates, and your insulin sensitivity is high. So when you eat those carbohydrates, the insulin works perfectly. It takes the sugar out of the blood, puts it into the muscle cells, and you get to use it as energy. Can everyone make sure they're muted? We got some noise in the background there. Okay, so anyway, so you want to do that, but what happens with low carb diets is you have really high insulin resistance and you have poor insulin sensitivity, and so you don't need as much insulin around because you're eating such low carbohydrate that it hides the insulin resistance. And you saw that big long list of all the diseases that are influenced by insulin resistance. You don't want to have insulin resistance. And that's what happens if you take somebody that's on a low carb diet. You actually give them a glucose tolerance test. So those graphs that Dr. Greger was showing in that study there was a glucose tolerance test. So if you challenge them with sugar, then you see how bad their insulin resistance is. And so you're still having all that damage done to your body because you're not treating the insulin resistance. You just don't know you have insulin resistance because you're keeping your sugar really low. So it's that equivalent of not fixing a broken hip, if that makes sense. And the other thing too, it's really important here is the only way you can really, so A1C is not good enough to tell you whether you have insulin resistance. Your fasting insulin, your insulin requirement, not so much either. And fasting blood sugar, not as much either. It's incomplete information about the presence of insulin resistance. Insulin sensitivity can be helpful. So so a glucose tolerance test can tell you your carbohydrate to insulin ratio. So people and when Stu talks here in a little bit, Stu and Sharon, he'll be able to tell you about his carbohydrate to insulin ratio, because anyone that's insulin sensitive or insulin dependent, whether you're someone with type 2 diabetes on insulin, type 1.5 on insulin, type 1 on insulin, usually the person will know what their carbohydrate to insulin ratio is. And what that means is, how they figure out how many carbohydrates they have in a meal, and they know how many units of insulin they need to cover that carbohydrate load. And so what tells you if somebody has good insulin sensitivity and low insulin resistance, or high insulin resistance and low insulin sensitivity, is that carbohydrate to insulin ratio. So if someone, for example, has to inject 1 unit of insulin for every 5 carbohydrates they eat, that's not very good. That means they have a lot of insulin resistance and very poor insulin sensitivity. So they need a lot of insulin to cover their carbohydrate. Or someone that maybe has a 20-to-1 ratio, so they only need 1 unit of insulin for every 20 grams of carbohydrate. That's a good sign. That means they have good insulin sensitivity and low insulin resistance. And so the other thing, I ask patients all the time, especially whether they're anyone that's on insulin, I'll say, so how many units of insulin do you need a day to control your blood sugar? And if it's like 100 units, 200 units, I just had a patient last week that's on insulin called U300 insulin. What that is 3 times the strength. So they were on like 40 some units of U300 insulin, which means like they're on 120, over 120 units of insulin a day. And so that's a sign they have a lot of insulin resistance. So there's even U500 insulin out there, so 5 times the strength. So, because so many people have such bad insulin resistance, they have to have more and more insulin to get their blood sugars to work, to get those down. And so so that's really how you find out if you have insulin resistance or not, is a glucose tolerance test or the carbohydrate to insulin ratio. Another thing I hear a lot is patients will come in and they're still eating kind of the standard American diet, but then and they have diabetes, and then they say, oh yeah, I've been checking my blood sugar. When I eat rice and beans, when I eat a bowl of fruit, my sugar goes really high. It's like, well, that's a sign that you have a lot of insulin resistance. And then once they get that fat out of the diet, get the meat, the cheese, the eggs, the dairy, the pork, the cheese, all the pastry, just all that refined carbohydrate, processed carbohydrate, and all that fat, especially the saturated fat, like in cheese, ice cream, pastry, chicken, red meat, pork. Once they get that, start decreasing that and getting it out of their diet, then they get the fat out of those muscle cells, out of the liver, out of the pancreas. And once they get that out, then maybe 3 months later, 6 months later, as they're working on that, then they eat that same rice and beans or that same bowl of fruit, and now their blood sugar doesn't go too high anymore when they eat those foods. And so now you're getting somewhere. You're actually treating that insulin resistance. And then the last point here before I'll take a break so I can answer some questions here is the number one cause of death in the population, as I mentioned earlier, of those with diabetes, is heart disease. And so why, I talk to colleagues about this all the time about, well, because there are lots of providers out there that say they think it's good to be on a low carbohydrate diet because they have a patient with diabetes, because they say, well, that their blood sugars get better, their A1C gets better, so yeah, I should have them on that kind of a diet. It's like, well, do you tell your patients that just had a heart attack or a stroke, that had a bypass or a stent, do you tell them to eat cheese and ice cream and chicken and red meat and pork? Well, no. Well, why would you tell a patient with diabetes to eat that? Because that's what you're telling them. If you're telling them to cut their carbohydrates, not eat lots of fruits and vegetables, beans, whole grains, that's where all your healthy carbohydrates are. What's left then is fat and protein is all that's left to eat. And that's where people reach for to get their fat and their protein is the cheese, the ice cream, the pastry, the chicken, the red meat, and the pork. And so now you're actually increasing their risk of having a heart attack or a stroke. So why would we do that? And so yeah, it's just kind of that. I'll let Charlie make a comment about that, because he likes to mention the kind of the conflicting information you hear. And plus, you guys need to get a break from my voice here for a second. So I'm going to unshare my screen and then let Charlie comment.
Yeah, so again, the information we receive is pretty confusing for sure. We are told not to eat carbohydrates. That's the message that our culture receives. But we get a message that causes cognitive dissonance. It confuses us because the other message that we hear all the time is eat more fruit and vegetables. And fruit and vegetables are carbohydrate. So when your brain is trying to reconcile what's the healthiest way to eat, it leads to significant confusion. You don't know what to do. And a lot of people have made the choice not to eat fruit, not to eat potatoes because they're carbohydrate. And that's sad because they're just making their insulin resistance worse. So thank you, Scott. And we're going to have Stu and Sharon Stephen kind of share their story with the group next. So fire away, and then we'll see if people have some questions afterward.
Thank you so much for inviting us to your class. We've now known Charlie for over 10 years, and we met Scott a little farther down on our journey. The way we usually start to tell our story is to kind of start at that point of how we met Charlie. And from there, then I'll let Stu talk about his life with diabetes. So we're both healthcare professionals, and I'm a nurse practitioner and had spent most of my career in cardiac teaching patients about diet and being very excellent at the American cardiac diet, the American Heart Association diet. And so I had just gotten a new job in Roseburg, Oregon, and I had left a very stressful job. And when I arrived at that job, they required a health physical for myself in order to clear. And on that physical, we had already moved, we'd gotten our house, everything like that. And on that physical, I almost didn't pass because my blood pressure was high. I knew my cholesterol was high, and I had pre-diabetes as well. And so at that time, I was very nervous about my own health, even though most of my life I was nervous about his health. And it hit me pretty hard at that time. And I saw this little advertisement in the Roseburg newspaper that said that there was a physician, Dr. Charles Ross, teaching a healthy eating class. Yeah. And so we kind of looked at it, and I tried to then talk Stu into going with me. I was enough worried about myself, but also thinking he would benefit if we could go together. So it was very, very hard for me to talk him into going. I bribed him, but this is now 10 years, almost 10 and a half years ago. It's January 2015. I drug him to the class. There were not many people in that class, maybe 16 by then. Were in that first class. We very much enjoyed it. And even though I drug him to the first one, he was excited about going to the next one. And from there, we have followed a whole food, plant-based diet since January, and we celebrated our decade of eating this way. So at that point in time, I'll tell you why I'll let Stu take over on why I'd been worried as a nurse and a nurse practitioner about his health. And had expected actually not to be married late in my life. So Stu, take over.
Well, thanks for inviting us again, and nice and Charlie and Scott and everybody again. So my story starts almost 55 years ago when I was age 12, and I developed type 1 diabetes. And at that time, 1971, I remember hearing I kind of grew up in the country, so we had our little town, our little country doctor, but he was telling my parents life expectancy at that time was 15 to 20 years, and I'm 12 years old. So obviously upset my parents. I'm 12, so I'm like, well, okay, 20 years, that's, when you're young, you live forever, right? And luckily, I grew up in Eastern Oregon, and I went to Portland. And at that time, it was called the Diabetes Treatment Units at Good Samaritan Hospital. But I learned about a summer camp in Oregon, and that next summer I was able to attend that as a camper. And that's when I actually met the endocrinologists, and so they had physicians there and nurses and dietitians. And so I kind of learned about diabetes, how to manage it, again in the 70s, which is pretty amazing. We had no blood testing. It was all, you tested sugar in your urine at that time. You had this little test tube, little space age looking thing. And I did okay. But again, always in my head, no, what's going to happen. And then as time goes on, you're learning, okay, how does this trajectory go? And it's like, okay, so first maybe you'll just lose a toe, but then it'll be your foot, and then you're above the knee amputation, and then your kidneys fail, eyesight to retinal neuropathy, And so that's kind of how I was looking at life at that time, just thinking, it's just not going to be that long. Luckily, after I kind of worked through after becoming a camper, I worked as a counselor at the camp. So I have a lot of friends that had diabetes, and sure enough, a lot of them were dying of kidney failure, heart failure. And these, some of my friends were like really healthy looking people, but at age 25, 30, they're dying from silent heart attacks. And it's just like, well, that's the story we have to live with. Luckily, there was some staff members at the camp. There was one nurse in particular, I remember, talked to me long about life expectancy and what to expect. And it's like, you can probably live a fairly long life. You can probably get out there to 30 years, maybe. A lot of people are going to 40 years now with the new technology and stuff that's available. And so that helped a lot. And then over the next 40 years, so I kind of graduated from college, worked in hospitals. I was a respiratory therapist, and worked at diabetes camp. So I kind of became medical staff and counselor at a camp in Idaho, and I worked there for another 30 years, so almost 40 years at summer camp. And again, a lot of that was helping children know that you can live fairly long, healthy life.
And you're not the only one.
And you're not the only one. It's just like, what kind of, until a lot of these kids, they're in small towns, and it's like, that's it. You're kind of this singled out person, and you're not supposed to really go out for sports, and you can't really do all this kind of stuff. But I was able to do some of that.
You had some trouble in your 30s when you had retinopathy.
So yeah, I kind of made it into my 30s, and at that time, so that would have been 20 plus years with diabetes, I started having some neuropathy. I had some retinal neuropathy, and I had some laser treatments. That's how they treated it back in those days in the early 90s. I was kind of just going along with that. At that point, I thought, okay, it looks like I'm going to lose my sight first of all these things that are happening. And got to the point where I'd actually worked for almost 30 years. And it's like, my wife at the time was like, well, you can retire anytime. But I kind of liked my job, so I kind of kept at it for a little bit longer. But then finally, it's like, if I'm going to have any retirement, I probably should retire. And so I retired at age 56. And that's when
we ended up in
Roseburg. So first off, I should say this wonderful nurse that I met back in 1980 when Mount St. Helens went off. I married her, and that's the camp nurse. So
I had to ask him, though. He didn't plan on getting married. I had to ask him to get married. He didn't think he'd have children. So it took a lot of nudging with the attitude, that he had.
Again, it's just like, why would I put somebody through that? And then I thought, if I'm going to have children, I'll never see them
get married,
graduate high school, get married, graduate college, have grandchildren. And guess what? Now I've actually seen all that stuff. So going back to Roseburg, meeting Charlie, and yes, I thought I was doing a really good job. And again, I know it's all changed now, but 20 years ago, the American Diabetes Association diet was kind of a low carb. That's how, counting carbs is kind of how you adjust your insulin. And so yeah, it was kind of like a keto diet. So, I could go home and have a pork chop and a side of peas, and that could be dinner. And boy, I think about that now, and it's like, well, how did I live through that? But going to Charlie's, and again, coming from a medical background, everything was kind of evidence-based that we did. And so Charlie just put it right out there. It's like he's showing Gregor clips and introducing us to all the other Bernard and all the other people that we definitely have been following for years now and learning how to do this. So like Scott was saying, with the insulin resistance. So I thought I was doing really well, but I was probably only taking about 75 to 90 units a day to keep my blood sugars okay. And as soon as we decided to give this a try, and we just, I don't know, I'm sure you've heard Charlie's story, but we kind of just went home and we emptied the refrigerator out and we started the next day. And
it was very frightening because I was between jobs. We didn't have healthcare insurance. It really felt that we were doing something very dangerous and scary, and especially scary with his blood sugars, what they did.
Yeah. And, and so Charlie had classes, twice a week when we were in Roseburg, and I would go to almost all of those and warn people that if you're going to do this, you need to be prepared. If you're going to cut the fat out of your diet and you are, type 2 or type 1, if you have that insulin resistance diabetes, it happens immediately, which was amazing. So I would say within 24 hours, my blood sugar is in the basement, and I'm just like drinking orange juice, anything to get my sugars back up. But we kept on the diet, and it took me a good 2 to 3 weeks to whittle down the insulin. And
so that you weren't low.
So I wasn't low. And I would actually call, I think I called Charlie. It's like, it's like, should I keep cutting my insulin down? He's like, you better, because your blood sugars are too low. So I ended up cutting about 2/3. So I did get down to where now my total insulin a day is kind of between 20, 25 units a day. And I, in theory, that's what everybody's insulin uptake is. It's just your pancreas produces that insulin and mine doesn't. So I have to kind of do it manually. I always tell people it's like an automatic and a stick shift. So the automatic just kind of does it, but I have to manually shift the gears and add the insulin.
And he was on a lot more medicine at that time. He was on medicine for blood pressure and cholesterol. What happened with those?
So it was a little slower than the insulin, but within a month or two, I was on 3 blood pressure medicines, and I'm fainting. It's like if I squat down and stand up, I'm just like passing out because my blood pressure is too low. So we slowly whittled those down, and one kind of disappeared, and then the next one disappeared. And then within 2 months, I was off all my blood pressure medications. And
off your cholesterol medicine.
Yeah, I needed to talk to my doctor, but I just went ahead and took myself off my statin. And when I went back about 3 months later and had all my blood tests done, it's like blood pressure was normal, cholesterol was normal, below normal, super low, normal. It's like, what the heck is that? And I was experiencing a lot of those which would become diabetes related things. So I had like some neuropathy in my feet. I was having I had like a stress fracture that wasn't healing. I had
Low energy.
low energy. And again, we kind of started in January, but that whole summer I kind of pulled the bicycle out of the garage and dusted it off and started riding around Roseburg. And that became my mode of transportation. So going to the grocery store, I just had saddlebags on my bicycle. So between the exercise and the diet,
You lost like 60 pounds in 6 months.
6 months, lost 60 pounds. Again, off all my blood pressure medicine, cholesterol medication, all the things that I was experiencing slowly went away. So at that point, we kind of thought, this is me, I thought, okay, we'll try this for a month or two and see if it makes any difference. And after 6 months, it's like, there's no way I could possibly go back to eating the way we did. So,
And kind of how our diet evolved. So we have been whole food, I should say we've been vegan for the 10 years and 5 months now. And our goal is to be whole food, plant-based. But there's times definitely eating out that food isn't as whole food. But we were not SOS free for a couple years. And we talk about salt, oil, and sugar. And that evolved. I like to add that evolved because I was doing everything he was doing. And I told you my health was bad going in. But my blood pressure went down to normal and my cholesterol still is higher than his, quite a bit higher. But it's at least in the range that you wouldn't want to treat it. And my pre-diabetes went away. But weight wise, I wasn't losing like he was. I was losing slowly, but it was much slower. And so that's when we figured out that we still could do better, that we could cut out the salt, sugar, oil. And for Stu, he tends to be really sensitive to salt. So if there's salt in the diet, his blood pressure's numbers will drift up. And also oil, as you learned from Scott, any kind of oil makes it that sometimes his insulin requirements go up a little. If we have oil because we ate out, then he needs a little more insulin the next day. And for the sugar, when we started doing that, that's when I kind of saw that I ended up matching him, losing like close to 50 pounds over more like 2-3 years. So it's kind of, sometimes it's helpful to know that even though he and I were doing the same thing, that the women have a much slower response, especially when it comes to weight gain or weight loss.
So at this point in time, it has changed our lives so dramatically. Like I said before, it was like just looking at death when that was going to happen. And now we're just looking at life. And again, we're retired and traveling the world. And, and we'll go to a new town. And what we do is walk it. Like, we're not going to get on the tour bus and do the tour. We will put our tennis shoes on and we'll just check out things and walk 10,
7,
yeah,
7, 8
7,
miles
8,
a day.
9, 10 miles a day and feel so good about it. And again, I life changing for me, for us. as a couple.
And that 2 years in Roseburg of feeling so healthy, we had gotten Stu retired early, and so I take maybe
So it seems like you've got a little freezing there. Maybe someone's using the internet at your place. So we're going to kind of switch off for a bit. And if your internet gets better, we'll bring you back in to finish off what you have to say. But for now, we're going to switch back to the group and see if they have some questions. We really appreciate your stories and participation. It's very inspiring. So, anybody in the class that has a question for Scott or for Stu and Sharon, and they may come back in here. I'm going to go to the gallery view here. Any questions from anybody?
I have a question.
Yes, Liz.
So I've been trying to transition off milk, cow's milk, and I've been using coconut milk. But I think that looks like it's not so good because it's 20% saturated fat in a serving.
You're so smart. You figured this out. It's not a healthy choice. Not
So
the
what
healthiest
about
choice.
so not nut milks either, right?
Well, almond milk, oat milk, soy milk. Gregor likes soy milk.
Okay.
My wife likes oat milk.
What about rice milk?
Rice milk, they're fine.
Okay. Just not coconut milk. Because, you know, when you shake up the coconut milk and you make a latte with the coconut milk, it tastes just as good as cow's milk. So,
It's
and
just
that's
as
why.
good. But yeah, it has the saturated fat, which is almost as unhealthy as the cow's milk.
So, would that result in a lot of fatigue? Probably would.
It sure could. You're learning.
Okay. All right.
Good
Good enough.
job.
Thank you.
You're welcome. Who else has something they would like to add? Barbara.
I was just curious as to why the difference between the weight loss of the couple that just spoke. She had a much longer time losing the weight and showing the results given the same diet they were eating.
Yeah, it's very common with males and females. So females notoriously have a harder time losing weight. Some of it has to do with hormones and or their premenopausal, perimenopausal, postmenopausal. And then also men have more muscle, more just on average, more lean muscle mass. So it's just easier to lose weight. And men tend to put weight in places that it's more unhealthy, like around the middle in the visceral organs. And that metabolically active fat, which is more unhealthy, is easier to lose. Your body knows it's the unhealthy fat, so you tend to lose that fat first. And women, more women are more pear-shaped. You've always heard about it's better to be a pear than an apple. So being a pear, that subcutaneous fat is more difficult to lose than the apple type fat around the middle. So for a lot of different reasons, it can be a lot more challenging for women to lose weight than men.
Okay, and one last thing I do want to add, talking about the coconut milk and the other milk. A few times we were referred to Trader Joe's soy milk, and we bought some and we both love it. So for those that are still trying to find a milk, I tried the oat milk and different things. I did like the cashew milk, but I have to say, I loved the Trader Joe's soy milk. Very good. And it was hard for me to get away from regular milk. And it was unsweetened. Another thing about it, it's unsweetened. So if people want to try that, be satisfied.
Thanks for sharing that, Barbara. Those of you may have noticed, Nathaniel's been on his treadmill during this, and food is important, and moving throughout the day is also important. And Dr. Greger kind of has encouraged us to keep moving throughout the day. So take note of that for those of you who are looking at the whole room. Liz, we're going to get one more question from you. Then I'm going to go back and see if Stu and Sharon, if they unmute, if they're able to communicate a bit more.
And
Go
real
ahead,
quick,
Liz.
real quick, I had a slide in my presentation about exercise and the importance of it, and that exercising muscle actually needs less insulin to let sugar come in. And so exercising your muscles, weight-bearing exercise, resistance exercise is really good for insulin resistance and diabetes. So, but yeah, go ahead.
Go ahead, Liz.
So what about nut milks?
It's fine. That's almond milk is fine. Cashew milk is fine. You know, most other mammals, they don't drink milk after they're weaned. You're doing this as sort of a tradition. You know, you like something white. It makes you think you could use water for the oatmeal. I mean, it works just as well if you just set your mind to it. So if you have to have milk, pick whatever you want. If you want a little more protein,
Just not coconut. Just not
just
coconut.
not coconut. Any other milk is fine.
Yeah, because it's so
Okay.
good.
Stu and Sharon, are you back? Can we hear you now? You want to try it?
They're still frozen.
It looks like someone is at your facility who's using the the internet, unfortunately. But it was a wonderful presentation, and we were able to get most all of it. It froze a little bit at times, but we really appreciate it.
Yeah, you guys are still
Okay.
frozen.
Still frozen. We'll get back to you.
If they
maybe
turn
again.
off their camera, we might be able to hear them though.
Okay, try turning your camera off and let's see if we can hear you. That's a good thought. Anybody else have a question between now and then?
Yes. Yes, I want to add on to what Barbara was saying. Barbara, you are on the money. You know what? I've gone a long way on this whole milk thing. I even bought the Nutra milk and I was making my own oat milk around the clock and I was exploring making nut milks and stuff. It's kind of fun. You can do it. But then when I learned that Trader Joe's soy milk only has soybeans and water, it's organic, and 36 grams of protein per small little carton of it, I said, that's it. This is my new protein source. And now I have it, quite a bit of it. I rely on it heavily. And the other thing I rely on heavily at Trader Joe's is the whole wheat pita bread. The sodium is less than the calories, so that's a good thing. Otherwise, I believe it's just whole wheat, water, and salt, and maybe something else. But again, the salt's less than the calories. I air fry it, and that's how I make my crackers, and I live off of those like every day. It's my staple. So that and the soy milk, yeah, game changers for sure. And then Liz, on the milk, if you want to be a little creative and resourceful, you could do 2 tablespoons of any nut butter or any nut or seed butter, and then just blend it with 3 cups of water, and then voila, you have your nut milk. And you could play two tablespoons of nut butter per 3 cups of water is what I wrote down from Chef AJ, I think, before. And then, and alternatively, if you want to have less calories, you could do 1 ripe banana and blend that with 1 cup of water, 1-to-1 ratio for banana milk. So another couple ideas you can have, but I'm still sticking with that soy milk. Me and Barbara will be on that aisle, depleting the soy milk.
So
Thank you.
Nathaniel, what about cheese? Nathaniel, what about cheese? Do you have any suggestions for cheese?
Oh, I do. And you're so lucky because I was just in Eugene and I hunted down your stores. The Market of Choice. Thanks to Liz. Thank you for pointing me in that direction. I went to Market of Choice. Actually, you know what? I'll do you better. I'm going to show you the cheese. How does that sound? We'll do show and tell.
Oh, that's
Okay.
okay.
Okay, so there was some cheese that I found, and it's called Tree Line Cheesemakers. Can you see this?
Line cashew cheese.
Cashew
Does-
cheese.
Goat
Does it?
stuff. Yeah, let me look at my camera, make sure you guys can see. Oh, there we go.
Garlic and
And what's great, and if you look at the ingredients, check that out.
can you read it?
Cashew.
Yeah, I can
I
read
can't
it.
see it.
It's cashews, water, sea salt, natural flavor, cultured brown rice, lactic acid, garlic, basil, parsley, and cultures. And but the sodium is just above the calories. And I know this is a high fat item, so it's more salty than your average. But I think this is the best you're gonna do if you want to buy pre-made cheese. I can't find anything better. So this is a
And you'll
good.
show it again. Good. It's called Tree Line Cheese Mate.
Yes, and they had and
Vegan goat style cashew
Yes.
cheese.
and if you check out the other market, what is that store called again, Liz? Market of Choice. That's right.
Market of choice.
And then I went to a different one. I found they had two other more different kinds. So the other one was garlic and basil goat style, and then these other two are creamy scallion and herb garlic. But these ones have a little more sodium, so I didn't buy. I just wanted to taste test them, but their ingredients are cashews, water, salt, cultured brown rice, lemon juice, scallions, garlic, onion, white pepper, basil, oregano, cultures.
That sounds very good.
So there you go.
Those are-
There's the answer to your cheese if you don't want to make it yourself.
And those are good decadent things, but they tend to be spendy. And if you're trying to lose weight, you don't want to eat too much of that because it's a lot of
No.
calories.
Totally, totally. That's true. Yeah, definitely consider it a treat. It's basically, it's like a nut butter basically with a little extra salt on this.
Okay, we're
Thank
going
you.
back to Sharon, Stu and Sharon. It looks like you're moving around now.
Can you hear us?
Yeah, we can hear you now.
Okay.
We switched over to the phone.
Okay, great. That works perfect. So do you have
Good.
any last words summing up or whatever? I think you did sum up a bit about changing from looking at death to living your life.
Yeah, that's the key right there for us.
All
Did we
right.
freeze again?
No, you're okay.
We're okay. Okay.
Any questions for Stu?
Yeah.
and
Any questions from anybody?
So he was saying how, his, like you mentioned, I think what's really important to take away from that is he was on over 70 units of insulin a day
Just wanna
because he had all
thank
that
you for
insulin
sharing
resistance.
your
And
story.
then he went down to like the
Okay.
physiologic level of insulin, which is about 20 to 25 units a day, which is what the rest of us that don't have diabetes are using. And so I think that definitely don't lose that point on how important that was. And then he doesn't have any of the complications of diabetes now that he reversed.
Kind of corrected any complications that were starting. They kind of corrected, and actually at almost 70, I feel better now than I did in my 30s.
Mhm. And it really showed not only did he have type 1 diabetes, but he had a lot of insulin resistance, and you don't think about that. So
Probably had type 1 and type 2 at the time.
you're welcome.
Have you guys ever touched base with the folks from Mastering Diabetes?
Which,
Yeah, it's
where?
in their book. Oh yeah, he wanted to know if you're familiar with Cyrus Kambata and
Yes.
Robbie
Oh,
Barbaro
yeah.
Oh,
from
yeah.
Mastering
Yes.
Diabetes. Yeah,
Yeah.
right.
We follow everybody. You should show your coin. He just got a special coin today. We've
Just came
been
in the mail
talking
today.
about doing this. When you have diabetes for 50 years, you can order your
Wow.
coin.
Little 50-year pin for a long journey. Well lived.
Congratulations to you.
Yeah.
We're thrilled.
Yeah, that was.
It just came today in the mail.
Oh.
Quite a difference from the 20 you were given.
Yes.
Mm-hmm.
Yeah, I definitely feel like it's all worth it now.
And you should see, we've got our, every winter we go to Mexico for 3 months, and we've just got a carry-on bag. he gets his extra bag for his insulin pump equipment. And we took 3 months of insulin pump stuff and his G7, and we just travel. And we do have a pressure cooker that we have in Mexico. So we do a lot of our own cooking. But we also try some of the vegan restaurants, and there are a lot of vegan options in where we go in Mexico. So the diabetes and or following our diet very strictly hasn't affected our travel at all. And we even had a meetup vegan group that we meet up with and just hear all sorts of stories, just like you guys are hearing tonight.
Where do you go in Mexico?
We go Puerto Vallarta and around there. So the little villages up and down the coast, but we fly into Puerto Vallarta, kind of on the west coast, central west coast.
I just want to
And-
know where the vegan restaurants are.
Yeah, actually there is that.
They're in the Cinco
Cinco
de
de
Diciembre neighborhood. And we get a little apartment right there, and there's 5 restaurants within walking distance of us. Yeah, and they do such a good job. We went to a little town of Yalapa for his birthday, and it was not a vegan restaurant, but they made the amazing whole food, like just their salads, their
Yeah,
what were burritos. I mean, they were just stuffed with just vegetables.
a lot of times all you have to do is ask.
Hmm.
You know, it's kind of like, well, I don't like oil, you know, if you could just saute that and just water, and you know, they're there to sell you food. So it's like, sure, we can do that.
Lots of vegetables,
yeah.
lots of fresh fruit. So yeah, we eat better in Mexico. We like their soy milk even better, unsweetened soy milk, than anything we can find in the States.
We should all come visit you guys down there.
Yes.
I've
In
never been to
July,
Mexico.
we're taking a trip to Norway where Stu's grandfather was from. And so that's an even bigger, farther trip. But definitely, you know, we have our health now, so we feel like we can travel.
Yeah.
Even more now that you can travel with that NHA travel, the Windstar cruises that serve our food's pretty awesome.
We're on that.
Excellent. And then
We're
another
on the
question.
we're on the NHA cruise. We
Oh.
leave Copenhagen on July 10th, and we're on 2 of them.
Ah, sweet.
Back to
That's
back.
how it is. And for those who
Yeah.
don't know, the NHA stands for the National Health Association. And they basically give lifestyle medicine geared towards the general public, not just medical professionals, like the American College of Lifestyle Medicine, which I was going to ask you, Sharon, if you're part of the nursing group yet.
You know, I thought about it, and I did like some health coaching, instructing, or not instructing, but I read health coaching books. We've read a ton. We've done lots of Veg Fest, and you know, I've tried to implement it in my work. I've retired twice, and I actually just started a new job yesterday. I'm probably not going to be able to implement this in my new job. I'm going to be a relief nurse at a jail. And so the food is very controlled there. But, you know, if I do see any way, definitely what I can do, you know, for Stu is I can make sure if people have diabetes, I make sure they have access to medical care that's going to keep them safe when they're incarcerated.
Sharon,
We have
Let's see. I'm not sure who's speaking. Go ahead. I'm looking.
our little RV park that we belong to. It's called Escape Town, the South Florida Florida. But the group happens to be in our park. So we have the Facebook page, and yeah, it's
It seems like it's cutting out again, but at least it worked for a while. I'm gonna look in
Yeah,
the,
sorry about that.
that's all right. We're looking for the chat.
I have a couple of questions.
Okay, go for it, Beth.
For Scott, what did you mean about insulin taking as much insulin as the rest of us without diabetes?
Yeah, so the amount of insulin that, so if you are a normal person with no insulin resistance, the amount of insulin your pancreas is kicking out in a 24-hour period to control your blood sugar is usually 20 to 30 units, kind of around in there. We call that physiologic insulin. So we would all die without insulin. So that's about how much. So basically, the amount of insulin that Stu is using presently is about the same amount of insulin that anyone without diabetes is using, just to control their blood sugar. So that's how
How much?
that's really significant.
So is that the long-term insulin? Is that what you're talking about? That people take the long-term to control physiological things?
Well, it doesn't really matter whether it's short-acting insulin on a pump or if you're doing a combination of long-acting insulin, intermediate insulin, short-acting insulin, because maybe you have type 2, or so even sometimes people with type 1 will be on multiple types of insulin. But these days, a lot of people with type 1 are on an insulin pump, which is just short-acting insulin that's getting secreted more like your pancreas is doing, little bits at a time all the time. And so we have a basal insulin level amount and a bolus amount, and so the pumps kind of more mimic what your normal pancreas is doing. But and ultimately, with the point we're making here, it doesn't really matter what kind of insulin, just how much insulin do you need in a 24-hour period to keep your blood sugars in the normal range. And normal is 20 to 30, whereas a lot of people, no matter what type of insulin or of diabetes they have, are on up to 100 units, 200 units. I've had patients on 300 units a day because they have so much insulin resistance.
Okay. Yeah, my dad has 14 units of long-term and then short-term as needed. So I just was
Right.
curious.
Yeah, so you just got to figure out how much total insulin between all the types of insulin he uses, how many units a day does he need, and then is his blood sugar normal? I mean, because if someone's on only 40 units or something, but their A1C is still like 12, 13%, they still have really high blood sugar. So that obviously they don't have enough insulin to keep their blood sugar under control. And plus, there's also some of the other oral medications, especially for type 2, that also lower blood sugar. So it's not just insulin. There's other medications that do different things to lower blood sugar.
So A1C can get as high as 13. Are you talking about 13, the number, like 13?
Yeah,
Yeah.
I've had patients greater than 14%. So it's a percent number. So A1C of over 14% means their average blood sugar is well over 300. If you were to kind of monitor the blood sugar 24 hours a day, 7 days a week for a 3-month period, it's over 300 if you're at like 14%. So we want to get it down, around 7% or a little bit lower, which is more like 120, 140 average blood sugar. So there's a A1C equates to a average glucose. It's just the kind of
Right.
blood test we do. Yeah.
Of 3 months. Yeah. I just didn't know it could get that high because I know like when you're supposedly when you're in your 70s, it should be, I mean, if you have type 2, it could be 7. If you're in your 80s, it could be 8. If you're in your
Right.
60s, it could, I mean, hypothetically,
Right.
depending on your situation.
Right. And the reason we do that is exactly what I was talking about, the results of those studies in 2008 that I was talking about. So when someone's 80, we might only want it to be down around 8%, because the older you are and the lower you drive the A1C or the blood sugar, the higher the risk for death because of the low blood sugars. And so those results of those studies that they ended early because it was killing people is a direct result of that philosophy.
Right, because the lows are much more dangerous than the highs when you're that old.
Correct. You are correct.
Right. Okay. Thank you.
Mhm.
Scott, I'm curious with your super U300, U500 patients, have you made some headway with getting, and what's been your approach? How have you done it?
Yeah, this has been a few years ago now. I don't have any patients on that. I have one patient on the U300 right now that I just started seeing, but I had a patient that was on the U500 a few years ago, and I know I got her insulin requirement way like cut in half, but then lost track of her. So I don't know how she did after that, because I left that clinic. But yeah, it can, and I told her it could take a while to reverse that level of insulin resistance. And I think after maybe 6 months, 9 months, she was able to drop her insulin levels and about by 50%.
How
So
did
that was making progress.
How did you start? Like, did you say don't eat at McDonald's? Like, what was your, like, that's someone who's probably eating a pretty, bad diet. And what was your approach?
Yeah, just like I do with anybody, I give them I go over that traffic light handout: green light, yellow light, red light foods. Hey, what are you willing to do right now? Not only just decreasing the red light foods, but just trying to eat more of the green light. Just try to, the positive approach, try to eat more fruits and vegetables, beans and whole grains. But then she'd say, well, it was making my sugars go higher, and I need more insulin because I was eating more of the green light foods. And I was trying to tell her, well, you have to really, hopefully, because she was still eating a lot of the red light also. And so I was like, well, I'm hoping that as you eat more of the green light, you'll start decreasing the red light. And she was starting to kind of get that. She was so focusing on eating lots of green light that, I cut out soda, and I cut out cheese, and I cut out red meat. And so we were making that progress. And I was trying to tell her that it's because of the red light foods that the green light foods make your sugar go high. It's not the green light foods' fault, it's the red light foods' fault. And so as I got over time, she kind of got that message. Okay, the red light foods are what's making it so that I can't tolerate the green light foods. And so I really got to get rid of these red light foods as much as I can. And I do tell patients on insulin with diabetes that, hey, in my experience with patients, the only ones I've ever had completely put their diabetes in remission, get off all their insulin, all their medications, are the ones that completely eliminated the red light foods. I know that sounds daunting, but I'm just giving you the truth, because that's, in my experience and with studies, that's what it really shows. And so don't let that be level of perfection. Don't let that stop you. But because any changes you'll make will be good for your health, even if it doesn't allow you to get off insulin or even use less insulin, it's still going to be good for your health to decrease those red light and increase the green light. But so yeah, I just kind of try to give those messages.
Scott, what's next week?
See, next week we have, it's Dr. Colgrove. So for pediatric nutrition and families. So he'll be speaking this Friday at the Grange, and then on the following Tuesday here. So we'll have our pediatrician, Dr. Eric Colgrove. So definitely hope you guys can join us for that.
You guys have been wonderful. Participation, Stu and Sharon, thanks so much for sharing your story, and everybody who participated, and Nathaniel with the cheese and the food in the local area.
And the Vegan
Thanks.
Fest was fantastic. The Vegan Fest was fantastic.
Yes.
Thumbs up. That was great. Fantastic. Had a good time.
I wanted to give Scott and Charlie an update on my Fosamax lady.
Okay.
So thank you for
Good
the
night.
article. And yeah, so she came back. She says